Alrighty, welcome everyone, and thank you for taking the time to join us today for Making Invisible Pathogens Visible, how to prevent surgical site infections before they occur. My name is TJ Crayson. I'm the Vice President of Sales and Customer Experience at SurfaceSite. And before we get started and kick things off, we just wanted to share a few housekeeping items for today's webinar. Just a reminder that as an attendee, your audio and video are turned off for the entirety of the webinar. If you have questions during the webinar, we want you to ask them as the webinar is ongoing. So please use the Q&A function in Zoom to type your question into the box. The Q&A is right next to the chat. We do have the chat turned off. So again, if you use that Q&A, we'll be monitoring that box throughout the presentation today and incorporating as many of your live questions into the conversation as possible and keep it interactive for all of us. Additionally, all of the information that we cover today will be accessible to everyone here post-webinar via a toolkit that will be emailed from the Leapfrog group with the presentation slides and supporting studies. As a member of the Leapfrog Group's Partner Advisory Committee, SurfaceSite is committed to providing innovative, effective, evidence-based prevention and environmental disinfection solutions that prioritize patient safety, quality, and transparency. Today, we're specifically going to be discussing the prevalence of surgical site infections in the operating room and a solution that identifies breakdowns and produces visibility in infection prevention processes that help facilities make improvements that ultimately prioritize patient safety. SurfaceSite is the exclusive distributor of PathTrack, and we are very proud to work with Dr. Randy Loftus, whose research in this space over the last 15 years has laid the foundation to develop this monitoring tool. So with that said, let's get started. As I mentioned a moment ago, again, my name is TJ Crayson. I'm with SurfaceSite, and I get the chance every day to work with leading health systems and hospitals around the country to implement and drive continuous improvement with their UVC disinfection programs and with their infection prevention efforts. In my over 20 years in healthcare, I've had the opportunity to work for leading organizations across the continuum of care, including Royal Philips Healthcare, the American Red Cross, and the American Cancer Society. But today, I'm joined by Dr. Randy Loftus at the Mayo Clinic. Dr. Loftus has 15 years of experience in anesthesiology and critical care medicine. He concluded his residency and fellowship at Dartmouth-Hitchcock Medical Center back in 2009 and transitioned to a career in academic medicine. Dr. Loftus specializes in perioperative infection control and acute pain medicine. He's authored over 60 publications and won an NIH R01 grant for his research. Dr. Loftus aspires to nationally implement an evidence-based platform aiming to significantly decrease Staph aureus transmission and surgical site infection development. Dr. Loftus, it's my pleasure to have you join me on the call today in the webinar today. I'll walk through the learning objectives next if you advance the slides, and then we'll turn it over to you.
TJ, thank you for the kind words. I'm very happy to be here. I'm going to all right.
Wonderful. Thank you so much. So today we'll be touching a little bit on what the current state of contamination and SSIs look in the perioperative arena and the impact, of course, on patients and patient safety. We'll be identifying breakdowns within current infection control practices and using that information to prevent SSIs before they occur. So really, we'll be demonstrating how mapping pathogen transmission pathways in the OR can lead to optimizing current infection control practices, including the big four, specifically hand hygiene, patient decolonization, vascular care, and environmental cleaning. And our last objective is to really talk about how to address those breakdowns with clinical decision software that over time can provide actionable improvements, decreasing SSIs and of course, performance metrics in the operating theater. So with that and those objectives, Dr. Loftus, I'd like to turn it over to you. The floor is yours.
Thank you. TJ, can you hear me? Because I'm struggling to advance the screen here for just 1 second.
I can indeed hear you.
Hmm. Oh, there we go. Right.
Correct.
All right. So the problem of surgical site infections. This is a significant issue because a recent study was just published in the UK that looked at what is the incidence of surgical site infections and the impact on the patient population. And the study involved 50,000 patients that had undergone open surgery. And the authors found that up to 11%, including 10% of patients undergoing low risk surgery, were affected by a surgical site infection. Now, that study was limited by the retrospective study design, but when you look at studies that have been done in the United States in the same time frame, which was 2017 to 2022, including 2 randomized controlled clinical trials and a large post-implementation analysis, the surgical site infection rate for all comers using methodology similar to the study that I just mentioned was 6.9 to 8%. So we're looking at a considerable risk for all patients undergoing surgery. And for the individual patient, when they develop a surgical site infection, there is harm associated with it. It increases their risk of death and hospital duration twofold. And it's also tied to increased risk of readmission. For example, the patients in the study by Guest et al., 16% of the patients that developed surgical site infections were readmitted. And of course, readmission and other factors such as direct care related to the infection treatment increase healthcare expenditure. Now, part of the pathophysiology of surgical site infection development, a large part of it, as you'll see in subsequent slides, involves the anesthesia workspace and particular reservoirs within that workspace. In a recent article published by myself and Dexter and Dr. Brown in the Journal of Hospital Infection, we looked at the epidemiology of surgical site infection development as it pertains to Staph aureus transmission or movement among anesthesia workspace reservoirs. And what I mean by movement is, for example, if a patient undergoing surgery happens to be colonized with Staph aureus in their nasopharynx, and that organism moves from the patient's nasopharynx to some other location that we typically measure, such as the anesthesia machine, then what you find is that there's an increased risk of infection. So for patients that are undergoing surgery where there's no movement of Staph aureus detected, the risk of surgical site infection is 2%. If there's movement detected of an isolate that happens to be sensitive or susceptible to the prophylactic antibiotic that was used for the surgery, then the risk of developing surgical site infection is approximately 11%. If there's detection of movement of a Staph aureus isolate, 1 or more, among those reservoirs that is resistant to the prophylactic antibiotic employed, then the risk of infection is 18%. And for each unit increase, if you assign each of those groups, the 2%, the 11%, and the 18%, 0, 1, and 2, for each unit increase, the odds is 3.59. So movement among reservoirs in the anesthesia workspace is a very important modifiable risk factor for surgical site infections. Now, you might wonder, well, how does this movement cause infection? Well, it can do this in several ways, and all of which are proven. So these organisms can be injected through the patient's intravenous catheter, and many patients undergoing surgery have multiple catheters. They have peripheral catheters, and some have central venous access. So it can be injected through the catheter, and every surgical wound has a hematoma. And through circulation, even 1 or 2 organisms that end up seeding hematoma, especially if there's significant blood loss and there are naders in the antibiotic plasma concentration, those organisms can infect those hematomas and lead to chronic infections. There can also be contiguous spread from one location on the patient to another over time within the 90-day postoperative period. So an example of this would be if a provider's hands are contaminated with Staph aureus, they're placing monitors such as EKG leads on the patient's chest. During that process, they contaminate the patient's chest, and then later on, that organism then spreads to the surgical site. That would be an example of contiguous spread. Another route would be direct contamination, where organisms move from patients or provider hands to the environment, and then they're transferred from the environment, such as, for example, dust from the boom, which is above the patient, and it settles into the wound when there's disruption of airflow in the operating room, which could occur for many different reasons, such as opening the door. And then, of course, you can have aerosolization of particles, where any reservoir that is contaminated with a causative organism of infection, such as Staph aureus, can become aerosolized through contact with particles and then ultimately settle in the wound. Now, the anesthesia work area is particularly problematic. And the reason why it's problematic is because of the high task density. So what is depicted here is a typical case, surgical case of 3 hours duration. This is an elective case. And what happened here is that one of my research assistants was sitting in the room during this case, and every time a provider, where yellow is anesthesia, purple would be the surgeon, and the black lines would be the circulating nurses. So every time one of those providers moved from the environment to the patient, he drew a line from where they started, where they ended up. And what you can see here visibly is task density. You can see, I hope, that the yellow lines, there are many more of them, and it's much denser than the activity of the surgeons and the nurse in terms of the patient-provider environmental interactions. Now, we know that the anesthesia environment has organisms that are much more resistant to antibiotics, much more likely to be transmitted than the patients that are on than the organisms that come into the operating room on patient reservoirs. So this type of movement can be problematic, and there is a need to wash one's hands when you're going back and forth, a basic preventive measure. Now, for the anesthesia workspace, it's been shown by Rowlands et al. And by Biddle et al. That anesthesia providers have anywhere from 75 to 300 opportunities per hour to wash their hands. Now, that's a very difficult thing to achieve, and it sets the stage for non-compliance. So the issue with task density is it leaves little time for compliance with basic preventive measures like washing one's hands. And in the anesthesia workspace, we are particularly prone to failure for those things, and it requires attention and optimization to get it right. Fortunately, we have a solution that has proven efficacy and effectiveness. So efficacy, that we know that it works, such as aspirin is effective in preventing heart attacks, and effectiveness, such as we know that a hospital can adopt and implement it and achieve the same endpoints as were achieved in a randomized trial. We have both of those for this approach, for this solution. And the solution is simply optimizing 4 basic pillars of infection control. One is hand hygiene. Another is environmental cleaning, especially frequently touched sites. Another is patient decolonization, including the nose, the groin, and the axilla. And then vascular devices, and that would include handling of syringes and syringe tips, as well as injection ports of peripheral and central devices, and how we manage our medication vials. So if we can optimize those 4 pillars, we have proven efficacy and effectiveness in preventing surgical site infections by over 80%. Now, the way that we optimize those 4 pillars is by monitoring Staph aureus transmission or movement among proven reservoirs in the anesthesia workspace. And when I say proven reservoirs, what I'm saying is that those are areas that we measure. While we could measure a multitude of sites, the sites that we measure are the ones that have over the last 15 years been proven to be tightly associated with transmission or movement and the development of infection. So we monitor how those organisms move. We then, through understanding typical transmission pathways, identify improvement targets. Once we identify the improvement targets among the 4 basic preventive measures, we provide feedback for system optimization. And then we work with the hospital systems to achieve optimization so that they can eliminate movement or transmission of Staph aureus and other causative organisms of infection. And by eliminating that movement, infections will fall. The way that we do the monitoring is that we use a case pair. Now, a case pair is simply in an operating room. Think of it as the first case of the day and the second case of the day. And the reason why we monitor a case pair is because just like we're interested in infections that occur vertically on the hospital floor within a patient and horizontally on the hospital floor between patients, we're also interested in movement or transmission of Staph aureus and other pathogens within a case and between cases in the operating room. So the observational unit is a case pair. 2 kits, 1 kit for each case. And the way that it works is that you, shown on the right, you can see the kit. It's a very simple kit. It's designed to sample reservoirs, the proven reservoirs, before the incision and after the incision. So for each site, you have 2 different measurements. And what we do is we measure the reservoirs that map to the improvement targets. So we measure hands before, during, and after care. We measure patient skin sites, the nose, the axilla, and the groin before and after incision. We measure the anesthesia machine, which is the most potent transmission vehicle in the operating room, at the beginning and at the end of care. And we manage the patient's the intravascular devices, typically the one that is primarily used for injection of the anesthetic agents. We have studied this approach intensely. So in 2019, we conducted a randomized controlled clinical trial. It was a cluster randomized trial at the University of Iowa. It involved 40% of surgeons, colorectal, gynecology, oncology, orthopedics, many other types of surgeons. And the surgeons and their patients were randomized to either usual care or to optimization of the 4 key pillars of infection control, using feedback for monitoring of Staph aureus transmission. And we, of course, monitored and tracked movement or transmission of Staph aureus during the case. And then the patients were followed for 60 days postoperatively for development of all-cause surgical site infections, not just those caused by Staph aureus, but all-cause surgical site infections. And what you see on the left is Staph aureus transmission, the mean number of isolates transmitted during a case on the y-axis, and then the group, usual care or the infection prevention bundle, on the x-axis. And you can see that in the treatment group with the bundle that was optimized, there was almost 0 movement of Staph aureus. And then on the right, you can see the impact on surgical site infections. The rate of surgical site infections was approximately 7% in the control group and 0.9% in the treatment group. So this cluster randomized trial demonstrated efficacy of these 4 pillars of infection control when optimized by feedback. The next step that we addressed was, okay, so we have efficacy, but what is the impact of the interventions when a hospital adopts them for all patients undergoing surgery instead of just those controlled in the trial? And what is the impact of the feedback. Can we disentangle the feedback from the four pillars? So Dr. Wall at MedStar Georgetown implemented he conducted a large post-implementation analysis to achieve those aims. So what he did is he implemented the four pillars: the hand hygiene, the vascular care, the environmental cleaning, and the patient decolonization up front. And he assessed transmission and downstream surgical site infections. Then he implemented feedback for monitoring of Staph aureus transmission. And he looked at transmission and downstream surgical site infection. So when you look at Staph aureus transmission in blue, you see that there were 24% of cases where there was detection of transmission before, and only 9% after feedback. And in both cases, the bundle was in place. And then with just the bundle, there was an 8% surgical site infection rate, but with the bundle and feedback, there was a 3% infection rate. So this study showed effectiveness where a hospital can implement outside of a randomized controlled clinical trial. There was uptake of the interventions, and it also disentangled the importance of the feedback component, the monitoring of Staph aureus transmission or movement.
Dr.
What you can
Loftus, if I could, sorry to interrupt you. If I could, one of the questions from the chat box right now is just, can you speak more to the sample size for the Wall study at Georgetown?
Yes, he enrolled over 1,000 patients.
Yeah, thank you.
And so what you see here in this particular figure, on the y-axis, you have counts of pathogens coming in through a particular reservoir, which is shown there on the x-axis in color. Patients are blue, the equipment is orange, provider hands are green, and red is the intravascular device. And you see time on the x-axis. So what this shows is that as Dr. Wall and his group were implementing, they were able to see a change in the counts of pathogens coming in and a change in the dynamics, what reservoirs were involved. And so during the study period, you can see a lot of red. So that was one of the early improvement targets. So the feedback was we need to improve intravascular care, and we used mapping to address how to get at what's causing contamination of the devices. They listened to that feedback, they implemented, and you can see that the red disappeared. And you see a gap there, which is the acute COVID-19 period, where we weren't allowed to monitor. But after that resolved and monitoring was resumed, you see sustainability of the impact that they had had before the acute COVID-19 period. And as they were doing that, shown in the upper right, you can see Staph aureus transmission where it actually increased during their bundle period with just the four pillars, but through feedback, it was dramatically reduced.
And Dr.
In
Loftus,
addition,
why, if I could ask, why just those reservoirs? What if there are additional, for example, environmental points that might be of concern by a facility? Why would we look at just the reservoirs that you shared from those four areas?
that's a very good question. So in the beginning, we looked at a multitude of sites in the operating room, and we looked at the ones that provided the most reliable feedback that could help guide improvement strategies. And over the last 15 years, we've conducted a multitude of studies, including a number of randomized controlled trials, looking at what reservoirs, when measured, provide feedback that can then impact the epidemiology of these organisms and downstream infections. So the reservoirs that we measure are the few among many that provide reliable feedback so that we can, in a cost-effective way, have a substantial impact on surgical site infections. And in it also, because we're culturing a relatively small number of sites that are valuable, it also impacts time. But if a particular site were implementing monitoring of Staph aureus and they wanted us to take a look at another reservoir, that's something, of course, we could explore. But the ones that we use as a routine part of our process, we're doing so because they're evidence-based.
Thank you so much, and that makes complete sense on the evidence basis. From the attendees, could you, if you wouldn't mind, walk a slide back and just reshare those reservoirs that are depicted here in the active groups?
Yes. So what we have here shown on down at the bottom, you see patients, which are blue. That would be the axilla, both sides, the nares, both sides, and the groin, both sides.
Okay.
You see the orange, which is equipment. That would be our anesthesia machine. That would be the adjustable pressure limiting valve and the agent dial. Then you see green, which are provider hands, and that would be provider hands before, during, and after care. And then you see red, which is the lumen, which is the intravascular device primarily used for the administration of the intravenous anesthetic agents during the case.
Well,
And what
thank you
we're
so
looking
much.
at is the counts of pathogens that each of those groups brings in.
And Dr. Loftus, you mentioned more than just S. aureus. So what other pathogens might be detected on these reservoirs?
We're looking primarily at the organisms that are more likely to harbor antibiotic resistance
Okay.
and pathogenic strain characteristics. So that would be Enterococcus, both sensitive and resistant, so including VRE. And we're looking at a number of gram-negative organisms: Klebsiella, Acinetobacter, Pseudomonas, Enterobacter, and then of course Staph aureus. Because when you look at what causes surgical site infections, which is our primary target, those are explain the bulk. Now there are additional pathogens that we could monitor, and this platform is set up to do so. And it's an easy add-on if there is a particular problem that's unique that can also be addressed and mapped.
Thank you.
You're welcome. Another important component of monitoring in the operating room, in the anesthesia workspace, is CFU, so colony forming units. What we've found over the last 15 years, and as shown in this recent article published by Dexter et al., is that when you measure these reservoirs and one or more of them returns greater than or equal to 100 colony forming units, then the risk of detecting a major bacterial pathogen that can cause an infection is substantially increased. This study conducted by Dexter involved almost 32,000 samples of those reservoirs that I described, which are 13 reservoirs per case, which again, they include the provider hands before and during care, the patients before surgery and during surgery, the anesthesia machine at the start of care, at the end of care, and the intravascular device. Those are the key reservoirs. So we had almost 32,000 of those in this study that were assessed, involving 105 operating rooms, involving 385 distinct days over 53 months, involving 9 hospitals over a 9-year period. And first, what I'd like to show is that every reservoir, getting back to your question, TJ, about why do we measure these reservoirs, you can see that each one of these reservoirs is useful in terms of providing us with information about detection of the key pathogens that are causing these infections. So orange is Staph aureus, gray is gram-negative, yellow is Enterococcus, and blue is methicillin-resistant Staph aureus. And you can see that the anesthesia machine, as well as intravenous catheter devices, provider hands, and patient skin sites are all important. They give us valuable information about the presence of these pathogens. And it's only if they're present that they can move. So understanding when they're present is key information. On the left, you see a chart that shows the reservoir and the probability of detecting a pathogen. And that's when the CFU are greater than or equal to 100. On the right, it's looking at what is the probability of one of those reservoirs returning or resulting in detection of a major pathogen when the CFU are less than 100. So when you look at the machine, the anesthesia machine at the start of the case, which is right here, and you go to Staph aureus, you see that there's a 5% chance of finding Staph aureus on the machine. at the start of the case when it's greater than 100. I lost my cursor. I'm trying to find it again. And on the right, you have CFU less than 100, but you look at the machine at the start of the case, you look at Staph aureus, and it's 1%, which is essentially negligible. So when the CFU is greater than 100 or equal to 100, then you have increased likelihood of detecting a major pathogen that can move from a non-sterile site to a sterile site and cause an infection. And it's that movement that you want to block. You want to block the presence of the pathogen in the first place, and you certainly want to block its movement. So a key component of monitoring Staph aureus is having a dashboard that reflects this recent data. So this is how it looks when you're using the simple kits to monitor Staph aureus movement. On the left, you see the reservoirs that are measured. And each of these reservoir sites maps to an improvement target. So this is the anesthesia machine at the start of the first case. This is the first case here of the pair. And then over here is the second case. This whole thing is the case pair. And it takes about 20 minutes to monitor a case pair. So when you are getting a sample of the anesthesia machine at the start of the case, what you're essentially doing is you are measuring terminal cleaning. When you measure the anesthesia machine between cases, what you are over here, what you are measuring is routine between case cleaning. So first you look to see what proportion of those reservoirs that the samples returning are greater than or equal to 100 CFU. And shown in the chart here, that would be depicted in black. If they're clean or less than 100 CFU, it would be green. And as we work with hospital systems, we're looking for more green because that's an indicator that we're working with a cleaner environment at lower risk of pathogen detection. We're not looking for perfection, we're looking for improvement. So the first step is to identify areas that might need improvement. So you can see that terminal cleaning here is an area where 95% of the reservoirs are indicating a need for improvement. Similarly, routine between case, 78%. So then the next step is to say, okay, what are the pathogens that are driving failure? So you go to the right. You look at routine between case cleaning here, you can see a number of different colors, including that would map to different pathogens, one of which is orange, which would indicate, as you see on the top, Staph aureus. So the next step is you say, okay, so one of the areas where I can improve is routine between case cleaning. And one of the key pathogens that can cause infection that's involved there is Staph aureus. There's also Enterococcus, and we can map that. But we're going to go look at Staph aureus and the system will generate a typical transmission map from the monitoring using the kits and identify what your improvement targets are. So in this particular case, it was mapped and it shows that the in-room provider in the second case was not washing their hands during the process of patient care, and that organism through that failed hand hygiene was transmitted to the patient's recovery area to contaminate the environment there. The lines between the two reservoirs indicate biochemical relatedness through the testing that those organisms are epidemiologically related. So the improvement target there in this case is obvious. And there's an automated report that generates that you can see failure of WHO 5 moments, but we always look at the charts, analyze them, and provide feedback and guide institutions through the improvement process. As you're getting the kits, collecting the samples, sending them back into the central laboratory, this data becomes available. You simply log in. Doesn't require integration. It's a cloud-based platform, and this is available for daily and biweekly use to work with your teams to address these improvement targets. The
Dr.
way that,
Loftus,
yes,
if I could there, is the case pair a case control approach?
no, it's not. It's not a case control. It's looking at it's more of a prospective observational.
Okay, thank you. And And I know that as you were discussing the reservoir related to the anesthesia station and its linkage to environmental cleaning, I think there was just a question in the chat in the Q&A about has there been changes in the past few years leading to the anesthesia workspace being a larger contributing cause of SSIs?
I don't think there's been any changes that have increased the risk of the anesthesia workspace being a contributor. I think it's been a problem all along.
Okay.
And the fact that it has not been addressed universally by hospitals, because the evidence is strong enough. It's been adopted, the NIH has looked at this. This is a very, very strong, very high level of evidence. This is something that really should be a new standard of care. And we have a new problem, we have a solution. And we have a persistent nature of surgical site infections. They continue to harm many patients every year. And part of that persistency probably relates to the fact that we have a problem that has not yet been addressed to the extent that it should be. So it's not that the contribution from the anesthesia workspace has gotten worse, it's that it remains unaddressed. Does that answer the question?
Thank you. And yes, looking at the attendee that asked that, I think that touched on exactly what that individual might have been going for. If not, I invite others to ask questions.
The way that we would implement this system, the standard way to do this is published again by Dexter et al. Here, is the first step is knowing your improvement target. Now, many hospitals, many teams know exactly where they want to start their improvement process. Some don't. So there are two choices. You either know or you want help knowing. And what we can do is work with Dr. Dexter through the University of Iowa. He can work with de-identified data very quickly and identify operating room specialty combinations that will show you areas where you have the greatest number of infections such that you can get your greatest return on investment. So you either know or you ask for help from us. That's step one. Step two is once we know what your target is, for each target population that you or we have identified, what we do is we then implement a very small number of those kits to survey the case pairs so that we can understand among the 4 key pillars what's working well and what might be improved, what might be in need of improvement. So that second step is a very simple step. You're looking at 15 to 25 pairs. It takes 20 minutes per pair. So if you do one a day, you're looking at just a couple hours per week. And it usually is going to take less than a month to get a really good understanding of what's working well and what may benefit from improvement. We generate a report of that sampling. It's called an executive report, and then we provide that information to you and work with the hospital to understand that so that they can take action on the improvement targets. The third step is once we know what the improvement targets are and we have an action plan moving forward to improve, is ongoing monitoring to achieve optimization of the system of the 4 pillars. That requires 43 to 75 additional case pairs, and that takes approximately anywhere from 3 to 6 months usually to get a hospital optimized. Once we're optimized, all of our 4 pillars are working well. Our staph aureus transmission, and that's the key indicator of optimization, is when your staph aureus transmission is at a low level. Then we know that now we're going to go into the maintenance phase, and that requires quarterly assessments of, again, that small number of kits. So every quarter you're looking at 15 to 25 pairs of cases. So that's the implementation process.
Dr. Loftus, how would you partner or collaborate with infection prevention during that process?
So that's a very good question, TJ. So when we start this process for a hospital, what we're looking for is immediately we're looking to engage infectious disease and infection prevention, as well as other stakeholders in the operating room that are going to be involved in these 4 pillars. So we're looking to work with anesthesiologists or certified registered nurse anesthetists, the students that are involved. We're looking to work with anesthesia technicians and med techs. We're looking to work with circulating nurses and surgeons. And what we do is we work with hospitals to form a team led by infection prevention. They would manage the data. And so when we provide, the team will have access, infection prevention as well as infectious disease, and anyone else on the team will have access to the data as much as they want to log in and look at it. But also, it's a great opportunity for infectious disease and infection prevention to have a window of insight into the operating room and to engage their perioperative colleagues on a biweekly to a monthly basis to look at what's working well, what can we fix, what's going wrong, how can we improve upon that. So to answer your question, we engage infection prevention up front, and we teach a multidisciplinary approach and a team-based approach for management of the data.
Thank you.
So for an example hospital, where I'm going to go back to Dr. Wall at Georgetown MedStar, and which is published, and all this information is online available. Looking at what rooms, so when you think about the patients that were enrolled, and there are the operating rooms, you can see there's a pretty widespread distribution across multiple operating rooms there. And that's one of the things when you implement this system, you want to look at this chart initially. It's available to see to make sure that the reports that are generated are based on the rooms that you're sampling. It's a quality check, but it also gives you an idea of how much of the operating room you're impacting. When the first step is for any hospital is you establish your baseline. So you identify your target, then you establish your baseline within that target. That's what's shown here on the left. And again, the counts of pathogens coming in for each of these 4 pillars. And early on, you saw a lot of red coming in from the lumen or the vascular care. There are other targets, but that was the one that really stood out. And you can see on the right, the dashboard. Most of the reservoirs that were sampled in that early phase indicated a need for improvement. There's a lot of benefit that could be seen here. Once you establish your baseline, that part of that is also looking at, okay, so yeah, I've got a lot of organisms, but are they moving? Are we transmitting? Or is it more than just contamination? And you can see here that the green line down here, that green line is where we want to be. And you can see that they're way above the green line up here. So it wasn't just there's a lot of contamination, there was a lot of movement, a lot of transmission, and that's what we want to block. The next step when you're looking at your baseline phase is to say, okay, so my transmission's high, I have opportunity for improvement in a lot of areas according to the dashboard, but when should I intervene? Is it the beginning of the day? Is it the middle of the day? Is it the end of it? And as you look at this graph, it shows that when you see increasing red indicates more detection. Very simple chart that shows that, yes, it's at the start of the day, the patient is coming into the operating room, so there's a need for decolonization. And the in-room providers here, that's the attendings, yes, but the in-room providers more so. So that could be residents, it could be anyone that's working with the attending. And you can see that there's more detection at the start of the case than there is throughout the case. So there's a really significant opportunity to address hand hygiene here. And you could do that with an early morning, for example, hand washing before you start your day, before you go into the operating room for the first time. Whereas the rest of the contamination, it seems to be pretty uniform throughout. Like when you look at the anesthesia machine here, you can see the same level of detection throughout. So it's not just you need to address it at the beginning of the day, you need to address it also routine between case cleaning. There's an indication for improvement there. So time is important. And my slides are stuck. There we go. Then you want to drill down a bit further, like we discussed earlier, and you want to look at what are the pathogens that are driving this. So here, early on, we saw that they had a lot of blue, which is Staph aureus. They have other pathogens too, like MRSA is yellow, and then you have other gram negatives, but we have a lot of blue with Staph aureus, which is a common cause of surgical site infections. So then on the right, we sought to generate a typical transmission map using those case pairs to find out how we could fix that. And even though we were measuring everything, where it focused in on was the patient nasopharynx at the start of the day and their groin, and you can see the biochemical connection between what was in their nose and what was getting injected into the intravascular device. So that's one of the mechanisms that we discussed earlier. So we have a problem that's now visible, very visible, and a problem that we can certainly fix. So on the left is where they started, lots of room for improvement, and on the right is where they ended up in terms of the CFUs. We're not looking for sterility, we're looking for improvement. And what they achieved was a 20% improvement across every one of the pillars throughout the study period. And that resulted in a 62% reduction in all-cause surgical site infections. So, and here's that same graph where I show their Staph aureus transmission going from 24 to 9% and their infections going from 8 to 3% in the feedback phase. So it wasn't the pillars, it was the feedback that got the pillars working. I think that we have for some reason, TJ, the remaining slides, I'm going to have to. Are there any additional? I guess that are there any questions at this point?
That's okay. I think I can bring up those additional slides. One question from the attendees right now, from the patient perspective, and given some of the reservoirs being tested are in the patient, is permission or consent required?
No, because for all the hospitals that implement this as quality improvement, it's implemented as a quality improvement process. These are standard of care procedures: washing hands, cleaning the environment, getting samples as part of the standard of care. And so when implemented as quality of care, consent is not required. One of the ways that surgeons do this is that they're seeing the patient in the clinic and they're explaining the surgical process, and they're explaining to them, okay, you're going to undergo a surgery here at this hospital. We do our best to prevent infections. We can't eliminate it, but we do our best to prevent it. And we have a system in place to do that. So when you get there, you can expect X, Y, and Z, so that they know what's going to happen and they know why it's happening. But it's part of quality improvement across the board, not just for a subset.
Dr. Loftus, given, and I know that the slides might not be that might spell this out, but can you talk a little bit about what would be the return that a hospital would expect in terms of investing in a process like this, from basically a cost return basis?
Very good question. So when you think about surgical site infections, the cost is, of course, at the patient level. You're talking about death, you're talking about hospital duration, you're talking about a 66% increase risk of getting admitted to the intensive care unit. So for one patient, it seems that it would be worth it in terms of the return. So you can help one patient. So just starting there. Then when you get into the economics, you look at it and say, what do these infections cost? Now there's a wide range. So surgical site infections can cost $3,000 for uncomplicated infections, but if they involve mediastinum, they could be over $100,000. So on average, multiple studies show that it's around $20,000. And what is the infection rate? Well, you're looking at an infection rate of, in some cases, as low as 2%. But if you look at the data I just presented, which is very recent for all comers to the operating room, in those 4 studies, it's probably closer to 10 to 11%. And so if you're an average hospital in America with 5 operating rooms, and you're taking care of 2.2 patients, 2 to 3 patients per day in each operating room for 5 working days a month for 250 days a year, your return on an investment is going to be over $2 million because the cost of implementing a system like this is less than the cost of one infection.
That's amazing, and truly amazing that taking a look and exploring exactly what from a monitoring perspective is happening can truly be preventative and increase patient safety. And Dr. Loftus, your work and your research here over the past 15 years is incredible, given its ability to impact patient safety. I think that there are some folks that are definitely inquiring about how they can learn more, but one of the questions I have before we get there is about hand hygiene. Was hand hygiene performed throughout the cases, specifically before and after? Can you speak more to that?
Sure, that's another good question. Hand hygiene in the operating room is typically abysmal. You're looking at 300 up to 300 opportunities per hour, and typically you're going to be looking at hand hygiene rates around 0.3 times per hour. If you increase hand hygiene to 8 hand decontamination events per hour, you can substantially reduce infections, which is one of the reasons why this process is so effective. So when we did these studies in the usual care, we were looking at hand hygiene that would approximate that, which would be 0.3 times per hour, because people were not getting feedback and not inspired to wash their hands. But in the treatment group, you were looking at a several-fold increase in hand hygiene above baseline. And that has been shown to be effective. If you can just do that, you're going to have an impact.
Thank you so much for speaking more to that. I think I'm looking at the Q&A box, and it looks like we've really tried to stay up to date on everyone's questions and answers. But I definitely understand there's some inquiries about, again, kind of where to go next. And Dr. Loftus, you suggested that really a facility can start the process with as few as 4 sample kits over two case pairs. Is that correct?
Yes, absolutely. That's what we call, back in 2012, I was working with a group that was working with what's called the Healthcare Engagement Network, and it was very brilliant, I thought, in terms of adoption and thinking about it. Where are you at now? Are you advanced? Where are you at on the curve? And so for folks who are just getting started, just thinking about addressing this as a new problem, yes, you can just start with 4 kits. It's ideal if you get the 15 to 25 done, and that's where we're going to want you to go. But you can start with 4 kits just to get an idea, a really good idea of what's working well for you in terms of those 4 pillars and what might need to be improved. And that takes a very short period of time to gain that valuable information.
Thank you. And that's something definitely the Surface Site team can assist with from anyone on the webinar today that's interested. I did have one other question I wanted to touch on related to UVC. There was a question about how long UVC takes to disinfect, and are there any side effects of exposure for staff? So if I can address that question specifically, UVC does have the capability to reach disinfection or a 6-log reduction on vegetative bacteria that would lead to SSIs. And that actually, depending on the device, can happen in really a matter of minutes from a configuration and device perspective. And of course, UVC is not something that's run in a room while people are in the room, but it's something that's used and controlled from outside of the disinfection space, so no one's exposed to the harmful effects of UV radiation. Great question. Thanks for the individual that asked that. And Dr. Loftus, specifically, thank you for taking the time to share your incredible platform with us, your research and the process to optimize practices over time to develop sustained improvements. Thank you for everyone here on the webinar who took the time to spend an hour with us. When it comes to patient safety, I think just by being here, everyone would agree that second best is simply not enough. We all have to be driving towards continuous improvement and prioritizing a culture of safety for patients. As we look to industry guidance, for example, such as SHEA, it's clear that facilities should be conducting regular monitoring and evaluation of infection prevention practices. And dollars and cents can be a huge motivator, but it's ultimately about achieving the highest standard of care for patients. So as a Leapfrog PAC member, Surfside is proud to work with hospitals and infection preventionists that truly aspire to be a Leapfrog A and those who are diligent in prioritizing patient safety. So to take advantage and work some of the process and get started with what Dr. Loftus shared today, we put our email contact in the chat box, and simply you can reach out to us at pathtrack@surfside.com. And again, that's in the chat box. But everyone on this webinar in the coming days is also going to receive a follow-up from Leapfrog along with the content to this webinar. You'll receive a survey. Please take the opportunity to fill that out. For anyone attending today's webinar, Surfside will be offering a 2-case pair assessment at no cost. All you have to do is reach out to us and we'd be happy to schedule that with you. It's actually very easy to take advantage of the process and collect those samples during a case pair, less than 15 minutes of sampling time during that case pair. And Surfside would provide all of the wraparound lab work and aggregate analysis software that brings the monitoring platform together from PathTrack. So please don't hesitate to reach out to us again, pathtrack@surfside.com. And Dr. Loftus, again, thank you for your time today and your incredible work.
Thank
Have
you.
a great day, everyone.